Hello, everybody. Thank you so much for having me. Thumbs up if you can hear me, just for the check. Okay, great. So thank you for that introduction. So tonight in my time with you all, my goal is to briefly review what we know about ACEs in adults in California, in children, how that impacts health, but then mostly focus on what is going on in California right now regarding the movement around adverse childhood experience screening and trauma-informed care. I have no conflicts of interest to disclose. I am delighted to be working with AAP Chapter 3 on our state ACEs Aware grant, and we'll talk a little bit more about that in this talk. So I also want to make sure that we have time to discuss activities and what you all might think would help in facing this really important issue. But I hope you'll be able to realize the impact of ACEs and adversity on health and impact on creating the environment for toxic stress physiology, the signs and symptoms of trauma, understand the components of our Surgeon General's ACEs Aware initiative. So where did this all start? 1998, here in San Diego, Kaiser, Dr. Felitti, who was in preventative medicine as an internist, was in charge of obesity clinic, and he was noticing his patients were having success with their weight loss treatments and therapy. And then one fateful day, kind of mistakenly asked a question of a patient about how much did they weigh when they first had sex rather than how old they were when they first had sexual activity. And in that conversation, the patient disclosed a long history of sexual abuse and molestation. And he started asking more questions of his patients and realized that many of his patients who were struggling with obesity, addiction, etc., had pretty significant histories of abuse. So they put together a robust survey and sent it out, 17,000 participants. And I really want to highlight that this was happening between 1995 and 97. So we can think about our cultural climate of disclosure and all at that moment in an insured population that was 74% white, and as much as 39.3% had college education or higher degree. So I want you to keep that in mind when we think about some of the populations and children that we serve. And what they found here was that even in this population of folks, more than 2/3 had experienced one adverse childhood experience in the following categories that I will describe, and 12% had had 4 or more. So by doing this questionnaire, and again, he will readily admit that these are not all of the adverse experiences that children face, but these were the categories that came to the top on questioning about people's past experiences before the age 18. In these 3 categories: abuse, physical, emotional, and sexual abuse; neglect, physical and emotional; and then household dysfunction, which actually now we're calling household challenges, that include a person with mental illness, a caretaker specifically, an incarcerated family member, witness to violence, substance abuse of a family member in your household, and a divorce or separation of your primary caretaker unit. And so with this, we have used this as a foundation from which a robust set of literature has been published. But we know that there are many other categories. For example, just, my goodness, this season, we're seeing horrific fires with displacement, food insecurity increasing, more exposure of police brutality and community violence, continued immigration challenges, separation of families, fleeing from traumatic experiences. And then COVID-19, all of these are risk factors for disruption of the safe, stable, nurturing relationships that our kids need to have to learn, physically grow, and thrive. So back to the data. We know, and depending on what date of publication, whether they say more than half or 7 or 9 out of 10 of the leading causes of death have associations with adverse childhood experience scores. And again, this is a raw score. This doesn't take into account if you have an adverse childhood experience of 1, that's sexual abuse that happened for 10 years, or if your categories were divorce, mental illness, substance abuse, and emotional neglect of a family member. So we can think about how we might approach this depending on what type of adversity. But we know that injuries, increased traumatic brain injuries, fractures, burns, behavioral health issues such as depression, anxiety, suicide, PTSD, unintended pregnancies, and also complications for the fetus are associated with adversity. Acquisition of HIV, STDs, cancer, diabetes, alcohol abuse, and then the economic impact is huge in terms of educational attainment. So you can see some of the odds ratios here for association with 4 or more. And this concept of 4 or more ACEs is going to come up again when we think about the ACEs Aware Initiative and screening protocols being proposed. So many of you have seen this pyramid before, but I really like to show this newer version. The first pyramid started with adverse childhood experiences, skipped the disrupted neurodevelopmental line to go straight to social, emotional, cognitive impairment, adoption of health risk behaviors, disease, disability, social problems, all leading to early death. And for those with 6 or more adverse childhood experiences, a much of 20 years life lost. What's also new about this, besides adding the disrupted neurodevelopment, which we're learning from the science animal models as well now in biomarker models in human populations, is the social conditions and local context and the generational embodiment of historical trauma. Because adverse childhood experiences don't spring from nowhere. These are rooted in the communities, culture, and society that we have built. So how does this actually embed in our body? And there has been a huge advancement in the science here. So we know and are hypothesizing now that you have an adverse experience in the absence of a safe, stable, buffering environment. All of your cortisol levels shoot up. You have an appropriate response to a stressful situation. Without that being turned off, you end up disrupting your neuroendocrine and immune function. So specifically, when we think about your neurologic system, we have dysregulation of the sympathoadrenal medullary and the HPA axis. And if we disrupt that, now we know we have more difficulties in modulating and turning off our stress response, that feedback loop. So some think about this as kind of a, can we have a rheostat where we can slowly adjust our stress response, or is it just all off on? This leads a lot to all on and really difficult to turn off. Greater activation and increased size of the amygdala. So fear responses, increased impulsivity, aggressive behavior. And in our immune systems, increased inflammatory mediators and markers, and inhibition of the anti-inflammatory pathways, explaining some of the increased risk for infection. Endocrine system can also be disrupted, looking at metabolic disease, but the inflammatory markers are definitely getting the attention when we try to explain how do we have a higher risk of cardiovascular disease and stroke from this. So this body of evidence for really explaining how this happens is growing. And then we get the joy of adding the new science of epigenetics to see how then this is a lifelong change in your body, even after stress is reduced, and how this could be passed from generation to generation. Well, how do we explain early death? We're looking at telomere erosions and actually association of shortening telomeres with the number of adverse childhood experiences. So what do we see? We see inflammatory conditions, asthma, eczema flares, endocrine conditions, diabetes, poor growth, and then all of those neurobehavioral symptoms and expressions of coping mechanisms. And Dr. Falili in his talks will say it's hard to get enough of something that almost works. And then also the concept of all behaviors are adaptive. So we're seeing behaviors that work when you're in a fight, flight, or freeze environment, but that don't work when you're trying to attend school, meet new people, interpret the facial expressions of your teachers and classmates. So just to hammer this point home, and this chart is from the ACEs Aware literature review, because I want to highlight what we think of as more the biological, physical health conditions, because I think we all intuitively are like, yeah, it makes sense, those risk-taking behaviors, the depression, anxiety, when you've gone through toxic stress experiences. But when we look at asthma, if you have an ACE score of 4 or more, and again, not really explaining which piece of it, you have an increased odds ratio, almost twofold. Allergies, dermatitis, eczema, urticaria, enuresis, encoparesis, obesity, and overweight. Failure to thrive, actually psychosocial dwarfism. So your growth hormones can be inhibited. So I want to highlight those because I think we are better at thinking about some of the behavioral health challenges and the risk-taking behaviors. But when you're seeing that next child with asthma or chronic urticaria that's getting worse, I want you to think about what's happened to them. Since we are at a school health conference, I really want to bring up these phenotypes that we may see in our development and learning. So if you have had trauma, it is possible that we've affected your working memory, we've affected your inhibitory control, and your cognitive flexibility. So it might be very hard for you to organize your thoughts, express yourself, adapt to a changing classroom, tune out some of those irritating noises. And short-term memory can result in some confabulation. And so these children might end up with ADHD diagnosis based on symptoms, ODD, or conduct disorder. Well, if we've known all of this, and the Felitti study was 1998, and a lot of our research has been developed since 2000s and on, of what's taken so long for the medical community to really hear this. And it's really taken many champions. So tonight we're going to highlight one champion for this in California, Nadine Burke-Harris, who in her clinical experience in Bayview up in Oakland, saw these patterns, started pulling together the research, and then doing her own research. And she has a very wonderful TED Talk that I'm sure many of you have seen. But if you haven't, it's really worth looking at to get yourself motivated for taking this on as a public health challenge. And she further wrote her book, The Deepest Well, alluding to the fact that just like the contaminated well, spreading disease in the community, our failure to address, prevent, and treat adverse childhood experiences is really hurting us. Well, how much? Let's look at California. So this is California specific data, and we can see that 62.7% of Californians have at least one ACE, but 17.6 had 4 or more ACEs. Remember in the original Felitti study, it was 12. And our breakdown by ethnic groups does show that there are some disparities, actually, with our Asian Pacific Islanders seeming to report less adversity. That doesn't mean it's not there, but it's really interesting to understand either reporting differences or community or cultural differences, which is helping mitigate the adversity overall. And so, well, what about children? Because all of these ACE scores are based on what happened to you before you were 18 years old when you're an adult. So the National Child Health Survey started adding adversity questions specifically. Interestingly, they didn't add all of them. They took out the sexual abuse question, and then they added some more language around witnessing neighborhood violence and income hardship, which poverty isn't on the original ACE scores. And they saw that even by age 5, that 12% had had at least 2 or more adverse childhood experiences. And you are more likely, if you have one adverse experience, to have more. When we look at race and ethnic income, poverty is a major risk factor for then acquiring these adverse childhood experiences. And Black non-Hispanic children have 33% in terms of 2 or more ACEs. So there are health disparities as well in thinking about ACEs, but I want to remind you that all humans of all race, genders, socioeconomic status, if we're talking 70% of people have had at least one adverse childhood experience, these numbers are huge. But ACEs are not destiny, not at all. And in fact, recently in the Journal of Preventative Medicine, where the original study was published, Robert Anda, who was one of the co-authors with Dr. Folletti, was very clear to say that he wants us to take caution when we're just looking at an ACE score, because this is population data. This is not individually protective or predictive, because there's so much going on with the experience of trauma. For example, one adversity of being sexually abused for 10 years may result in a lot of disruption, where a child may have 4 or 5 and had lots of support, nurturing, and caregiving, and actually be in a pretty healthy shape. So I just want to keep that in mind when we're thinking about screening efforts. And what we're trying to do is, how do we make sure we're increasing the positive experience load, the positive childhood experiences? And Dr. Robert Sagi out of Tufts is working on thinking about HOPE, health outcomes through positive experiences, and positive child experiences scores to help us understand the full picture of children. So in 2019, the Office of California Surgeon General, Nadine Burke-Harris is our first Surgeon General ever, launches the ACEs Aware initiative as part of her early childhood health equity priorities. And Dr. Nadine Burke-Harris and Gavin Newsom set the bold goal of reducing toxic stress and ACEs by half in a generation. And so let's think more about the ACEs Aware initiative. So this is a plan to help us all learn more about trauma-informed care and screen for adverse childhood experiences as part of that effort, to treat, understand the science and how that affects health, and integrate that into our assessment and management planning, with a special focus on prevention in the prenatal and early childhood parenting years, to coordinate our networks of referral and treatment to make them more effective and accountable and easy to navigate for children, adults, and providers. And our school health system, our school mental health systems are going to be a critical component, as they always have been, with helping kids buffer and overcome adversity. And we're going to advance the science of toxic stress and improve the efficacy and evidence of therapeutic interventional targets. So who is supposed to screen? So the interesting part of this is they have put money where their mouth is, and that Medicaid providers, Medi-Cal, are incentivized $29 per screen that can be conducted annually for children 0 through 21, and then 18 that with a screener specific, the Pearl screener 0 through 18, and then an adult ACE screener 18 through 65. After you're 65, I guess we do not care how many adverse childhood experiences you've had, because the state will not pay you the $29 for those. And many providers can do this, but the concept is that this is being done in the context of the medical home, where there can be an ongoing relationship. So the screener itself, here is an example of the Pearl screener. So part 1 represents those 10 categories of adverse childhood experiences. And then part 2 incorporates the social determinants of health and some of those other adversities that we know directly impact the caregiving and nurturing structures for our children. Why they did it this way is because they really wanted to adhere to all of the literature and data that we have, which is based on those 10 categories of what I'll call the Felitti ACEs, so that you can match apples to apples and not include some of the other things. But they still want these questions to be asked. Here's an example of what we call a de-identified screener, where a family would look at this and just look at the questions and count yes or no in their mind, and then put a score at the bottom for each of these sections. And then providers are supposed to take that information and ask about associated health conditions. If the score is 0, that's a low risk screen. If the score is 1 to 3 without a health condition, that's kind of a medium risk screen. If it's 1 to 3 with health conditions, that also can be considered a higher risk screen, and 4 and above is a high risk screen. But the state is collecting data really thinking, are we under 4 or over 4 with the total score of ACEs? So the huge part of this, because ACE screening honestly is one component of trauma-informed care. When we think about trauma-informed care, there's actually many different nuances to the definition. But when we pull from the SAMHSA definition, trauma-informed care aims to realize the widespread impact of trauma and understanding its pathways to recovery, recognize the signs and symptoms of trauma in patients, family, and staff. So hopefully at this point, you can think about some of the patients and families that you've worked with and how some of their behaviors or physical complaints might be related to a traumatic experience. Integrate this knowledge about trauma into policies, procedures, and practice, and actively avoid re-traumatization. So originally this was thought of as the 4 R's: realize, recognize, respond, and resist traumatization. But now folks are adding more R's to resiliency as our 5th. So what could this look like in pediatric practice? In whole, this is a systems change to really incorporate what happened to you instead of what's wrong with you, and for providers to resist what we love to do, which is just to fix everything, and truly be collaborative with our patients. On an individual level, though, I encourage you to think about ways that you can increase trust, transparency, give voice and choice to children, and truly do shared decision-making and collaboration. For one example, the way I do this in practice is even with the tiniest children. Do you want me to listen to your heart first from the front, or do you want me to listen to the lungs from the back? Should I look at the right ear first or the left ear first? Explaining what I'm doing head to toe. Asking parents at the end of the visit, I need you to come back for a weight check. When do you want to come see me next? If they tell me tomorrow, I will guide them that maybe 1 to 3 months we want to think about. If they tell me 8 months, then I might guide them back, but not putting out prescriptions for them. And those are things I can do every day on an individual level. When we're thinking about both promoting health and wellness and then having protective factors in place, we really need to think about resiliency. And so at the time that I prepped these slides, there were 6 domains of wellness endorsed by the California Office of the Surgeon General for promoting and preventing and treating adversity. But now we've added a 7th, which is nature, to the official wheel. And so for anyone, regardless of if you've experienced adversity, balanced nutrition, mindfulness practice, physical activity, quality sleep, all can help you return to baseline from your stress responses. So you have stress that goes up and down and doesn't become toxic. Supportive relationships, we really want to increase the affiliative response. We talked about all the fight, flight, freeze, adrenaline, cortisol, but we want to increase oxytocin. And how do we do that? Hugs and connections. And then we want to make sure that we're really supporting parents when they have strengths. This is a strengths-based approach. So when I'm feeling lost, I always ground myself in Dr. Kenneth Ginsburg's 7 C's of resiliency. And you can even think about this for yourself too. Am I doing activities that I increase my confidence? Am I giving my kids places where they can learn new skills and be competent and have a contribution to society? Are we talking about value systems and problem solving together? Are we talking about coping strategies? When things are hard, how do you calm yourself down? When you're angry, what do you do to calm yourself down? You can incorporate those into your well child visits. And then for families that have experienced trauma, control is a big deal. If you can find a way to give back something that they can control, this can really help you move forward in your collaborative relationship. We are certainly not going to do this alone, and addressing adversity and promoting resiliency is going to happen in a community, with schools being a huge part of this. You know, businesses investing in people and trying to prevent some of those social determinants of health, poverty and resource poor families being one of the big risk factors, which is why in the time of COVID, we're very, very worried that all of those precipitating factors for adverse childhood experiences that matter to our health, intimate partner violence, child abuse, are really on the rise. So the National Child Traumatic Stress Network has wonderful toolkits for many of the different domains of traumatic experiences. And I just wanted to point out that they have a toolkit specifically for schools in how to identify and respond with some great information about how to help kids and families. So in sum, ACEs are really common. And I would say we're already doing this. We just want to do this better and more evidence-based and more thoughtfully so that our systems don't end up re-traumatizing kids and families. If you haven't seen the ACEs Aware Initiative, please go to the website. All of us can be trained. And actually at this point, more than 14,000 providers in California have undergone the 2-hour free CME, free MOC training that is required in order to bill for Medicaid, but is a wonderful introduction to true primary care clinical application of trauma-informed care. And this will affect us all because there's going to be a state-based media campaign about ACE screening saying, hey, your doctor may ask you this. They're reaching out to police departments, justice departments. So more is coming. Our AAP Chapter 3 has one of the state-based grants for from ACEs Aware. And many of our wonderful partners here in San Diego also have received funding to help increase awareness and provide you all the tools, the support, the peer support, the forums to really engage with this to improve your clinical practice. So thank you very much for your attention. And these websites are very useful in both learning about trauma-informed care and what am I going to do when we start to have these conversations about adversity.